Assalamu alaikum. This presentation is on Sjögren syndrome manifestations of salivary glands affection, covering the clinical picture, the investigations, the updated evidence-based management.
Sjögren syndrome is one of the major causes of xerostomia. This is a chronic autoimmune inflammatory disorder characterized by lymphocytic infiltration of the exocrine glands in multiple sites, primarily the lacrimal and the salivary glands. It can occur alone and then termed primary Sjögren syndrome, or in conjunction with another autoimmune rheumatic disorder when it is a secondary Sjögren syndrome. The prevalence is somewhere around 0.6% of the general population. Highest prevalence in the 4th and the 5th decade of life. It's 90% of the patients are females. The focal lymphocytic infiltration of the exocrine glands may lead to germinal center formation, consisting of around 80% T cells and 20% beta cells. This will produce antibodies and cause focal sialidinitis or inflammation of the lacrimal gland. Cytokines may also play an important role in the pathology. The clinical picture would be that of a dry eye, the keratoconjunctivitis sicca, and a dry mouth. There will be extraglandular manifestation as well, including transient or chronic bilateral enlargement of the parotid or the submandibular glands, seen in between 20 and 30% of the patients. There may be some oral complications, including dental caries, candida infection, difficulties with eating, swallowing, and speaking, and a general sense of fatigue and arthralgia. In the primary Sjögren syndrome particularly, there is a high risk of developing a non-Hodgkin's lymphoma. The risk is more than 18 times that of the general population. There is also a high risk of developing autoimmune thyroiditis. 1 in 8 patients would develop autoimmune thyroiditis, or autoimmune hepatitis, interstitial lung disease, and interstitial nephritis. Interestingly, the minor salivary glands of the palate may not show the full manifestations of Sjögren's disease, the lymphocytic infiltration of the salivary glands. The diagnosis of Sjögren's disease could be established by objective measurements of saliva outflow and objective measurements of tear secretions. Salivary gland biopsy, usually taken from the lower lips, minor salivary gland biopsies, would also confirm the diagnosis and help in the scoring of the chronic inflammatory process. Estimation of the autoantibodies in the serum autoimmune antibodies in patients who have Sjögren syndrome could have the antigen, the SS-associated antigen A or B, and recently the ultrasound high frequency intraoral imaging is used in the grading and confirmation of the diagnosis of Sjögren syndrome. Xerostomia patients would describe several symptoms. Only 4 of them would correlate positively and significantly with the objective measures of salivary flow rate. These 4 symptoms are oral dryness when eating, the need to sip liquids to swallow dry food, difficulty in swallowing, and the perception of too little saliva. These are the most important 4 symptoms. Moving to examination, the oral examination of patients with xerostomia would show problem with the teeth itself. It may be dried up or it can have caries or gingivitis. The tongue may be dry and fissured. There may be evidence of candidal infection. There will be absence of any signs of salivary pooling in the floor of the mouth, and there may be some purulent discharge in the salivary gland ducts. Dental caries are usually much more prevalent in patients with dry mouths, particularly the older patients and patients who have dental restoration works, and those with gingival problems or gingival recession. And the extraoral examination would include examination of the major salivary glands, whether they are enlarged unilaterally or bilaterally, and whether there is any abnormalities in the saliva on pressing on the salivary glands itself and watching for the fluid coming out from the major salivary glands ducts. It will also include examining the neck for any lymph nodes and examination of the eye and the lacrimal system.
Investigations for cases suspected of having Sjögren's syndrome and its salivary glands manifestations would include some of these four different groups. The first group is the investigations of the salivary whole saliva output or selective from some special glands, measuring the unstimulated and the stimulated flow rates and also the salivary chemical composition. The second group would be blood tests, including complete blood count, total and differentials, and the autoimmune markers, including the anti-nuclear antibodies and anti-specific antibodies in the Sjögren's disease, including the antigen A and antigen B antibodies and the rheumatoid factor, serum immunoglobulins, and also erythrocyte sedimentation rate or C-reactive protein. The third group includes imaging of the salivary glands, usually in the form of ultrasonography. Occasionally, sialography would be needed to exclude any obstruction of the ducts or stenosis. Magnetic resonance imaging can be useful in complicated cases. Computed tomography is not usually done to avoid the unnecessary exposure to irradiation. And finally, salivary biopsy can establish the diagnosis, usually taken from the lower lip. Some minor salivary glands from the inside of the lower lip, which show the lymphocytic infiltration around the parotid, around the salivary glands tissues, or fine needle aspiration of the major salivary glands in case there is any suspicion of a lymphoma.
Saliva will be collected for a specific length of time. This is usually 2 minutes for the stimulated whole saliva and 5 minutes for the unstimulated whole saliva. You start first with the unstimulated whole saliva flow rate and then follow this with obtaining the sample of the stimulated whole saliva. When the patient is asked to chew on a standard piece of paraffin wax or a gum base and repeat the test in the same way, like spitting of any collected saliva in a standardized tube without swallowing it. The amount of saliva collected, whether stimulated or unstimulated, can then be obtained by weighting the tubes and subtracting its pre-weight from the newly weighed after being loaded with saliva. The values would be expressed in grams per minute, which are considered equivalent to milliliters per minute. The salivary gland ultrasound grading system was developed to be used in patients with xerostomia in general and with Sjögren's disease in particular. The grading system depends on three things: the major salivary gland contour, whether it is regular or irregular, the echogenic area, usually the pathological areas will be hypoechoic. If the hypoechoic areas are in the form of bands or in discrete multiple areas, and if they are in multiple areas, whether they are rounded or irregular, localized or diffuse. If the gland contour itself is irregular, then this is either grade 3 or grade 4. The first three grades would have a regular gland contour. If the hypoechoic band is present, like a complete band of hypoechoic, then it's again either grade 3 or grade 4. The first three grades, 0, 1, and 2, don't have any hypoechoic bands. If there are multiple hypoechoic areas, if there aren't any of these hypoechoic areas, then this is grade 0. If they are localized and round, then this is grade 1. If they are diffuse but still round, it's grade 2. If they are diffuse and round but with the other two criteria of irregular gland contour and hypoechoic band, this is grade 3. If they are diffuse and irregular plus the two other things, echogenic band and irregular gland contour, it's the highest score, number 4. And these are examples of ultrasonography for normal patients in this column, and for Sjögren syndrome patients in the other two. The upper row contains ultrasonography of the parotid, and the lower for ultrasonography of the submandibular. In the normal patients, you could see a homogeneous echo and no abnormalities in the gland contour itself, either the parotid or the submandibular. In the patients who have Sjögren syndrome, you could either see localized hypoechoic part, localized in the parotid and more generalized in the submandibular. This is grade 1 and this is grade 2, and the ultrasound score would therefore be 1 + 2 = 3. Or in a more advanced case, you could see hypoechoic bands, like bands of hypoechoic and across the parotid or the submandibular. This is grade 4 in the parotid and grade 4 in the submandibular, and the total ultrasound score would therefore be 8.
A parotid sialogram will be obtained by injecting a radio-opaque contrast medium through the parotid duct, and this would show the complete duct system of the parotid, including the arborization into the interglandular small ducts and acinar spaces. And you could see in Sjögren syndrome the typical picture of a budding tree. A tree in bud. It shows as if this is a tree with early budding, multiple tiny area collections of the contrast in several areas around the arborizing duct system. CT scan would rarely be used to avoid the extra unnecessary exposure to irradiation, but if it is done, it would show multiple small nodular areas, hypodensities areas across the gland bilaterally. It may show also a diffuse enlargement of the gland itself. You usually consider a three-dimensional imaging type when there is a suspicion of lymphoma complicating the Sjögren's disease. Moving now to the management, and starting with two parasympathomimetic medications, both approved by the FDA for the use in Sjögren's syndrome. Pilocarpine was the oldest. This is a non-selective muscarinic agonist, works on MA3 muscarinic receptors and stimulates the residual functioning salivary tissue. And at least 2 randomized controlled trials had showed its efficacy and confirmed significant increase in saliva output, as well as improved subjective measures, including a sense of moisture in the oral cavity. It works for a few hours, somewhere around 2 or 3 hours. That's why it is taken in 3 times a day, starting with a dose of 5 milligrams orally and titrating the dose up if required, up to 10 milligrams 3 times a day. It has the highest possible recommendation grade. Level of evidence is A. It would take some time before its full efficacy is shown, somewhere around 2 months after starting the medication, before the maximal effect is reached.
But the real issue with pilocarpine is the side effects, because it's a non-specific muscarinic stimulant. It acts on several other systems in the body, and the side effects would include excessive sweating, rhinitis, urinary and gastrointestinal tract disturbances, and risk of having untoward cardiovascular and pulmonary effects as well. It's therefore contraindicated with gastric ulcer and uncontrolled asthma and hypertension, or in patients on beta-adrenergic blockers. Because of the numerous side effects, attempts were made to explore whether pilocarpine could be used locally in the mouth. A randomized controlled trial tested pilocarpine as a mouthwash formulation, 1% or 2%, used for 1 minute. It increased objectively the salivary flow, and this lasted for 75 minutes for both concentrations, the 1% and the 2% pilocarpine, and there were no significant side effects. The subject had also had these sensations of increased salivary flow, and this was particularly noticed with the 2% concentration. And obviously the use of pilocarpine locally would reduce the side effects. The other parasympathomimetic is Cevimeline hydrochloride, which is a derivative of acetylcholine. It is an acetylcholine analog. It works selectively on M3 receptors, muscarinic M3 receptors in the lacrimal and salivary glands, and other exocrine glands such as the sweat glands, the pancreas, and the intestinal glands. But it can also increase the muscle tone and motility in the GI and the urinary tracts, but have very little effect on the cardiac and the pulmonary receptors. It has been approved by the FDA for the relief of the xerostomia in patients with Sjögren's syndrome. And in at least 2 randomized controlled trials, Cevimeline hydrochloride was tried on primary and secondary Sjögren's syndrome patients, and in both randomized controlled trials, the oral Cevimeline improved the xerostomia, subjective sensation, and the hyposalivation objectively. It's recommended to give Cevimeline at 30 milligrams 3 times a day orally for both the primary and the secondary Sjögren's syndrome patients, and this recommendation has taken the highest class 1 recommendation level of evidence is A. Several other medications and drugs were used to control the systemic disease that cause the hyposalivation and the xerostomia, the most common of which is the Sjögren's syndrome. These include the interferon alpha in a lozenge form. This was shown to enhance the salivary flow rate in the primary Sjögren's syndrome patients. The anti-tumor necrosis factor agents, monoclonal antibodies such as infliximab, was not recommended because it couldn't show any effect. Steroids had also been tried earlier, but again showed no objective effects on salivary flow rates. The non-virilizing dihydroepiandrosterone was also tried in the primary Sjögren's syndrome with no much effect. There wasn't much evidence to support the use of local oral cavity stimulants or lubricants and protectants for hyposalivation and xerostomia, except perhaps for the use of chewing gum. Chewing gum can stimulate the reflex secreting of saliva by the act of chewing itself. So that's the only one of this group of local stimulants and lubricants that has some evidence to support. But of course, patients would find some of these products useful in alleviating the sense of dryness of the mouth, even without objective increase in the salivary flow rate, and professional judgment and the patient preference would support a use of a specific product that the patient would find useful. Another monoclonal antibody, the rituximab, which is a monoclonal antibody that reacts with the CD20 antigen present on about 90% of the beta cells lymphocytes. A patient with primary Sjögren's syndrome were treated with this infusion of rituximab weekly, and they showed a very good response. And there was a subjective improvement in their symptoms, and the salivary gland functioning also improved, and the peripheral beta cells count has decreased. and if labial salivary gland biopsies were taken, it could be shown that the lymphocyte infiltration, particularly by the CD20 positive beta cells, had decreased, and the effect of the monoclonal antibody was sustained for 10 months. Measures to adjust the diet to help in relieving the sense of dryness of the mouth start with frequent and regular sipping of water. Drinking water not only relieves the dryness of the mouth, but also eases in swallowing and hydrate the tissues in the mouth and clean the oral cavity. If dry food is to be taken, it should be accompanied by frequent sips of water. In general, avoidance of dry or hard or sticky or acidic food would be helpful, particularly food of extreme of temperatures, too cold or too hot, and sugary foods that may increase the risk of dental caries in patients with hyposalivation. It's best to try and cut down or avoid caffeine or alcoholic beverages because they would dehydrate the oral cavity tissues and cause general dehydration and increase the sense of oral dryness. A diet that contains food rich in moisture would also be helpful. Vitamin C tablets as a reducing agent break down the disulfide bonds between the cysteine residues in the proteins, and this leads to a decrease in the viscosity of the saliva. But frequent use of vitamin C is not recommended because citric acid and sweeteners are often added to the vitamin C tablets to reduce the bitter taste. The citric acid and the sweeteners could have erosive effects on the dental enamel. Smoking should also be avoided as much as possible, as it can further irritate the dry oral cavity and also cause further dryness of the mucosa. Next is oral lubricants and protectants, starting with olive oil, which is one of the simplest and cheapest oral lubricants and has an established benefit in the treatment of dry mouth. Also, commercially available oral lubricants can be of help. These are predominantly based on carboxymethyl cellulose gel to give the solution some viscosity. They also incorporate other substances like antimicrobial agents, lactoferrin or lysozymes or lactopyroxidase. These are naturally found in saliva and can be added to the carboxymethyl cellulose to give some antimicrobial effect. Oral lubricants and antimicrobial salivary substitutes can be applied as a bolus or as a slowly released intraoral device in the mouth. The use of a humidifier, particularly at a bedside during sleep, can help in alleviating the symptom of dry mouth and also dry nasal passages. And saliva substitutes or artificial saliva. Using oral mouthwashes, gels or rinses or sprays and or artificial saliva can all help to reduce the discomfort and improve the function of the oral cavity momentarily. These oral care products are specifically formulated for the dry mouth. They contain no detergents, they have a mild taste, they contain antimicrobial routine. They also contain a thickening agent to provide some viscosity, plus their protective properties. So they have different composition and different viscosity. Among these agents is of prime importance the carboxymethyl cellulose, a mucopolysaccharide, but other agents can also be used, including glycerate polymer, gel base, or natural mucins, hydroxyethyl cellulose, xanthan gum, glycerol, linseed, polyethylene oxide, plus the addition of some salts, preservatives, and sweeteners. These products, either mouth rinses or mouthwashes or toothpaste, can all have a short-term relief. from the sense of dryness in the mouth up to 4 hours or so, and can also help in keeping the patient's mouth and teeth and gums healthy. They can improve the pH buffering in the oral cavity, and if you incorporate synthetic detergents like sodium lauryl sulfate or osmoprotectants like glycine betaine, it also improves the oral cavity functions, but again only for short periods, few hours, maximum 4 hours at a time. Another important category in the home remedies for dry mouth is preventive dental care, because extra measures should be taken to prevent the oral complications from low salivary output, including frequent dental and oral evaluation. Between 4 and 6 months, you would need to have a check with the dentist, and radiographs of the teeth should be performed annually. And to prevent dental caries, meticulous oral hygiene and a low sugar diet and regular use of topical fluorides are recommended. In fact, the daily use of a neutral pH sodium fluoride is the most effective means of preventing rampant hyposalivation-induced caries, dental caries. And if the patient is using any dentures, it's important to prevent fungal colonization by daily immersion of the dentures for 30 minutes in chlorhexidine solution, either 0.12% solution or 1% sodium hypochlorite solution. Also, it's important to have the dentures adjusted to avoid any friction or injury to the oral mucosa, and use dental adhesives because the dryness of the mouth may prevent proper alignment of the dentures, and to consider the use of implant bone prosthesis, which may have lower side effects. But if oral candidiasis develops, which is a common complication for patients with salivary gland hypofunction, it needs to be treated promptly. Chlorhexidine 0.12% solution used twice daily, 10 milliliters, to rinse the oral cavity, swish and spit at least twice daily. Or if angular cheilitis has developed, the use of ointments containing either nystatin or triamcinolone can be applied topically 4 times daily, or the use of clotrimazole torches 10 milligrams, again 4 or 5 times daily for at least 10 days. Systemic therapy with antifungal agents should be reserved for patients who are immunocompromised or cases that are refractory to topical therapy. Another line of management would be to try and increase the salivary output, particularly from the major salivary glands, in patients who are still having residual functioning salivary gland tissue. And various products, including the chewing gums and hard candies, lozenges and sprays, have all been tried. They must be sugar-free and non-acidic, of course, to avoid any dental erosion. Chewing gums in particular is of some help in producing some salivary output through the reflex action mediated by the periodontal receptors by chewing. And of course, additives can be added to the chewing gums or the other products to help in preventing dental caries, like sugar-free xylitol containing and mints and candies and the gums. Chewing gums will stimulate salivary flow, but not much, and can provide some transient relief of xerostomia. Although it is effective in stimulating saliva, the usefulness of chewing gum in the management of xerostomia is limited. It is, however, more effective in reducing the dryness of the mouth than all the mouth lubricants, particularly in patients who had radiotherapy or hemodialysis.
By this, we come to the end of this presentation on the salivary glands manifestations of Sjögren's syndrome. Assalamu alaikum.